There's a medical anthropologist named Wade Davis who said something like this. I can't quote him exactly, but I love what he said. He said, "The other person's culture is not their poor attempt at being you. It's who they are, what they value, how they see the world." We're always, maybe human nature-wise, trying to make other people or expect other people to adopt our values and see the world as we do. But that will never happen, so we have to respect the fact that that will never happen. When advanced illness, such a sensitive topic, and the end of life, perhaps there is no more sensitive a topic. When these things are before us, we have to respect the cultural differences that are surfaced. Palliative care, very unfamiliar to most people everywhere, and certainly unfamiliar to most Latino patients who have immigrated recently to this country or the children of such people. As I said, it's new everywhere, really rather new approach, certainly a new word. And so it's our job too to educate people about what do we mean. Sometimes when we make a referral, oh, let's get the palliative care team in here. Well, what is that? Well, they help people who have a serious illness. We don't even explain it well to ourselves. So we need to come to terms with that, understand what we're talking about when curative care options are running out or unlikely to be effective, that we have made a transition, hopefully smooth, hopefully mixed earlier with palliative approaches that bring comfort to the person. There should never be a time when we say to our patients, I can't do anything more for you, therefore we'll send you to palliative care or hospice. We are all doing things together to bring the very best treatment and comfort for patients all the time, all the time. The emphasis changes with advanced illness. In many other cultures and countries today in the world, truth-telling about prognosis is not the norm. But in America, we have made it the norm just within a generation.
Ahí es donde yo miré que pues también los médicos, aparte de ser insensibles de cómo dar la noticia que tienes una enfermedad mortal, que acepten que un familiar tuyo que no sabe tanto inglés sea tu traductor en algo tan sensible como es tu vida.
Latino families feel abandoned or rejected, or they feel that they've been turned away from care because of their income or their lack of insurance. When I think about that population and how they view or could be served by palliative care, these are some conclusions I've reached. The first one is that the whole concept is unfamiliar. So hospice is new, palliative care is mysterious, and beyond that, culturally, I think that Mexican immigrant families, Latino families, are still the default position for them with serious illnesses. Please treat all you can, give all the treatment that you can. That's the assumption. That's why we've come to your hospital. That's why we've come to your clinic. We want everything that you can do. So the concept of doing less aggressive care, while it's a familiar concept to us healthcare providers, doctors and nurses, is not necessarily a bit familiar to our patients and their families and might be kind of jarring. So that when we ask a question like, well, would you want a feeding tube? Let's say, we're talking in advanced care planning mode. That could be a very peculiar question. It's incumbent on us to frame it and phrase it and explain it better, even as a question, if it's going to be meaningful. The reason that could be so peculiar is because the answer, the default answer, might be, well, yeah, I'd want a feeding tube if you recommend it. If that's what you think I need, that I'd want that. So somewhere we need to reach through and together take that journey of there are many ways we could proceed. And there are some treatments that we can offer, and there are others that we usually would not in this situation, or we can't make this decision for you. Let's talk about it together. Those kinds of conversations and approaches take time, but they're worth it.
Y ya cuando llegamos al hospital, pues ahí nos dijeron, pues la pueden dejar morir o pueden ya, podemos tratar de resucitarla. Y ya, nosotros quisimos que la resucitaran porque, pues, ¿quién quiere que su familiar se muera? ¿Verdad? Y en realidad yo siento que no fue una buena decisión porque ella sufrió más. Esa última semana estuvo como, la amarraron porque ella le empezaron a poner muchos tubos y ella trataba de arrancárselos, y su forma de ellos de arreglar el problema, como no le podían dar tanta morfina para controlarla, la amarraron a la cama. Y pues para mí eso fue muy doloroso, ver cómo ellos lidiaban con un paciente que está desesperado. Y ya de ahí le dio mucha fiebre, la pusieron en una cama de hielo para bajarle la fiebre. Y pues ya de ahí se los fue.
The stakes are high. When we don't do that well, we have people who are living with guilt or sorrow or grief or feelings of betrayal or anger toward us, even disabilities that could have been prevented. So those are high stakes. In our world, healthcare, those are the highest stakes. They're much more important than keeping people alive longer, but to help with quality of life and feelings of satisfaction about one's decisions.
Sí, ponte lista.
Hello, Jose Antonio.
Hi.
I don't have very good news to tell you. I'm sorry. Your AML leukemia has gotten worse.
¿Qué dice?
Que no tiene muy buenas noticias para ti.
¿Por qué? At this point, it's too late for a bone marrow transplant.
¿Y le hacer un trasplante?
Sí.
¿Sí? Eso es
Sí.
bueno, ¿no?
Uh-huh.
I'm very sorry about that. And you can speak with the palliative care unit and with your family about it.
Que podemos hablar sobre esto juntos.
Pero nos va a seguir ayudando.
Sí, claro.
Sí.
¿Por qué dijo que
Thank
está
you.
sorry?
Let me know if
Porque
you
está en
need
cama.
anything.
Ya, muchas gracias.
Thank you. Gracias.
Que necesitamos hablar sobre cómo estás. Para ver si encontramos una opción o algo.
A ver, dime qué fue lo que pasó. Explícame. ¿Qué pasa?
Ay, no sé ni cómo decirte esto, pero es que no te quise decir nada con papá.
¿Por qué no? A ver, dime qué es lo que pasa. Explícame, por favor.
Pues que ya no lo pueden seguir atendiendo aquí.
¿Cómo que ya no lo pueden seguir atendiendo?
Es que...
¿Es porque ya no tenemos dinero? ¿Porque no tenemos seguro?
Ay, no sé.
Pues entonces, es que ¿qué fue lo que dijo? Yo oí que dijiste que un trasplante. ¿Qué fue lo que
Eso
dijo?
mentí. Es que papá ya no tiene solución.
¿Cómo que ya no tiene solución?
Pues ya no. Ya. Necesitamos, cuidarlo en sus últimos días.
¿Cómo que sus últimos días? Ay, no. Hija, ¿qué vamos a hacer? ¿Qué vamos a hacer sin tu papá?
No sé.
Ay, no. ¿Estás segura?
Eso me dijo la doctora, yo no sé.
home is not home. So imagine yourself being a Mexican immigrant to Oregon. And when you came originally, the Mexican economy was terrible, and this was where you could provide for your family. But you never really intended to stay here. You love Mexico, that's your home. That's where quite a lot of family was left behind, as in my father's case. So you always expect to go home. That kind of thinking, which is very common to Mexican immigrants, famously so, influences many things. It influences the milieu in which you live and work. You may seek an enclave, a neighborhood where everybody speaks Spanish. You may continue to shop for groceries at the Mexican marqueta and continue to have Mexican goods in your home when you can obtain them. You surround yourself with Mexico and what's familiar from your home because it is still your home. Another thing I think that's important to know is immigrants come here from Mexico not usually because of great love of American culture. There might be some of that, but not necessarily. Most come to be able to earn a living. And when serious illness befalls you, you may not be able to earn a living. So your whole reason for being here is pulled out from under you, but you may be stuck here because you have no means to go elsewhere. So picture yourself as that Mexican immigrant again, now with a serious illness, with a defined prognosis, probably less, say, than a year to live, and only very limited curative types of medical treatment options left, say an advanced cancer. And that person may not be able to get home again. And that can be rich in a negative way, in terms of how they experience their illness or make meaning of it. That person might feel betrayed. That person might feel deeply disappointed that the dream was never achieved of getting to be home. Those are some of the things that lie behind actions I've commonly witnessed in my community in rural Oregon, where a Mexican immigrant dies of an illness who couldn't get home, but the family and even the larger community chip in and do everything possible to get the body home for burial. I think that that's been something, at least I've heard, true of immigrants from many countries. I think we find it still to be very common here among Latino immigrants, especially from Mexico, where the proximity to the homeland has kept alive many dreams that can't be achieved or won't be achieved for various kinds of life decisions, but sometimes things that one can't avoid, like serious illness. And in American hospice, try as we might, we can't help a person die at home if home is really elsewhere. So we have to think about it differently, explain things differently, but most of all, understand things differently. The cultural and spiritual connection with homeland is very rich and can be an asset and can be beautiful, but it can also cause grief.
Él sí extrañaba México. Él antes de enfermarse, como un año antes que él se enfermara, él estaba planeando de que nos íbamos a regresar a México, que él quería irse ya mejor a vivir a México, a trabajar allá, que porque él ya se había cansado de estar aquí todo el tiempo trabajar y que él quería disfrutar el tiempo que él estuviera bien en México y enseñarle otros ejemplos a sus hijos. Pero meses nomás que él tenía esos planes, él se enfermó y pues ahí se quedó todo. Cuando él podía todavía caminar y todo eso, él se quería ir, pero a la vez no se quería ir porque decía que él no podía arrastrar a sus niños a México, porque él iba a morir de todos modos. Dice, sí, yo me voy a México, dice, yo voy a morir, pero los que se van a quedar sufriendo en México son mis hijos. Y mejor no. Mejor me quedo aquí y en lo poco que me ayude el hospital y el programa ¿cómo dijiste que se llama? Del cuidado paliativo, yo voy a estar aquí y hasta donde Dios diga que ya no más.
Latino patients and families, in my experience, make decisions in families, more rarely as individuals without the family context. And like all of us, make decisions based on information that they understand, and make decisions that are based on the underlying values they have about life in general, including their spiritual faith and values. In fact, one of the most interesting things I've learned in working with Mexican people all my career has been that even deceased members of the family are consulted at times. The sense of what would my abuelito have wanted? What would my abuela advise if she were here to advise us about this baby with a heart defect? Or about this decision point? Or what to do with this high-risk pregnancy? So people in the family, even people who are no longer present or can't be in the room, are consulted, and their values are brought to bear on healthcare decision making. What that should teach us is to be very mindful about involving the family, very skillful in identifying different segments of the family, and reaching them all in the ways that go where they are and serve what they need. So one pictures a mixed family like that, and all of the cultural influences. That means that we as healthcare practitioners and professionals need to be very discerning about the different influences, even within that one family, so that we can reach through well. So if we are part of a family conference, or if you find yourself at the bedside of that elder, at least you might not be able to perform as perfectly as we all might wish, but you will have something that connects with each and every one of those people, perhaps a little differently, and can help them together to understand what's going on, to reach decisions when they have to be made, and to reach them as harmoniously as possible. We won't get there if we don't have that kind of discernment and recognition of culture and background. This kind of mixed family brings to bear certain issues that we all need to know about. When we talk about understanding our patient's culture, it's important to me always to convey it's not just about such things as folk beliefs or illnesses that are believed in that country that we don't recognize. A lot of people think that's what cultural competence is about. That's an important element, to be sure. But it involves really understanding where our patients and their families are really coming from, where they're living, and that involves knowing things about their immigration status and their income and their language and the values, like any patient, that they bring to bear, and their spiritual life. But the family values that really guide Mexican immigrant families serve, in cases of advanced illnesses, to let people stay at home cared for very tenderly by family members. In fact, in the hospice world, where with other populations we might kind of market what we can offer or persuade that it's a good idea by saying, hey, a nurse can come to the home and a nurse's aide can bathe your mom. Many times in dealing with Mexican families, the nurse might be especially welcome, but the aide touching or bathing mi mama, mi papa, that's something it's up to us to do. That's something we do. That's something we're privileged to do, something he would like us to do. The caregiving that is done by Mexican families that I've been involved with at the end of life, or people needing palliative care, because curative care has reached its limit. The caregivers in those situations in Mexican families, Mexican-American families, I haven't heard them complain. I don't hear them complain. I do think they have health burdens. I think it's very stressful. I think sometimes they burn out. But they don't tend to complain because it's part of the cultural milieu that we take care of one another in our family.
Él decía que, pues dice, si ya no me voy a curar, ya no me voy a componer, dice, yo quiero soportar los dolores un poco sin medicina. Puedo controlar el dolor o él me puede controlar, dice, yo voy a tratar de controlarlo a él. Yo le preguntaba a él, ¿a dónde te duele o cómo sientes? Dice, es algo que yo no puedo explicarlo, pero me duele todo, un dolor horrible. Y era una de las cosas de él, que él siempre decía que él estaba muy agradecido con el hospital, con las enfermeras, con los doctores, que él sentía que era una carga para ellos, que él no quería molestarlos, que prefería aguantarse el dolor y lo poco que ellos le ayudaban era mucho para él. Que porque era mexicano, que porque él era mexicano y era pues extranjero, no era de este país, y él pensaba que era pues una carga para el hospital. Dice, aparte de ser mexicano, dice, dirán, ay, aquí vino un mexicano y quitándole el puesto a un americano, ¿no? Ocupando un cuarto de un americano, que a lo mejor un americano lo ocupa y yo estoy aquí. Y él sentía que era, que a lo mejor los doctores, es como que eso pensaban ellos. Él se le venía eso en la mente. Que si él pedía algo o algo, él, que como que era algo incómodo para ellos atenderlo.
Sí, nosotros no sentíamos que teníamos el derecho de decir nada, más que nada porque pues tú recibes los servicios como te están haciendo un favor y cómo es que vas a decir algo. Sí, y muchas de las veces es como no tenías nada y cuando te ofrecen algo, pues no lo quieres perder y tratas lo más que puedes por aceptar todo lo que te dicen, inclusive como te digo, gritos o lo que sea, uno dice, ok, pues me están ayudando, que hagan lo que quieran y no es así. Y lo más que nos pasaba a nosotros es que la teníamos que llevar demasiadas veces a emergencia para que agarrara la medicina para el dolor. Entonces los del cuidado paliativo me dijeron que ellos podían controlar el dolor y para mí eso era bien importante porque no me gustaba ver a mi hermana sufrir. Y de ahí empezó 6 meses terribles donde era básicamente morfina en su cuerpo todo el tiempo. Ella a veces no quería estar como dormida, ella quería vivir, pero no nos dieron la opción como decir qué es lo, ella quiere como tener una vida activa, o hay actividades, o hay ejercicios, o por ejemplo hay un nutriólogo, cosas así.
In American mainstream culture, we view fatalism as almost a negative thing, like you accept bad things and shouldn't. But it has a positive association in Mexico of acceptance of what life gives you, what maybe God gives you, the resilience, as well as hard-working and brave nature that's valued in Mexican culture is a great asset in dealing with difficult situations, health problems. The family loyalty, filial piety, those are very great assets. So we do not have our nursing homes in Oregon filled with Latinos with disabilities or injuries or advanced illnesses because they're almost all at home being cared for by family. Two, I think it's important to know that the life and the experience overall of many Mexican immigrants in our state is not the greatest, where the person who's come here to earn money for the family might be acknowledged as a hero for the risks that perhaps he's taken in his village back in Mexico. Up here, he may be reviled or a victim of hate crimes or ridiculed or simply living in poverty for a very long time. Not at all a hero, not at all even regarded as a full human being in the society. So that kind of discrimination and prejudice and life experience is very hard to take, and it's exaggerated then when a serious illness falls one. All of those things and many more we could talk about are serious pressures, serious griefs, or causes for sorrow and anxiety. What's really amazing is how beautifully many handle their situation anyway. And again, there are cultural values that are assets, spiritual life being one of them. I have learned not to make assumptions, but nonetheless to be aware that it's likely that my Mexican patients and Mexican American patients have a core of spiritual faith that is serving them. It helps with acceptance and making meaning of illness. It can help with making meaning of pain and suffering. It can help with reconciliations with family members as one approaches the end of life. It can help a great deal with acceptance of spiritual professional care in the palliative care team, which many of my other patients don't accept. They say, no chaplain. I rarely hear that from my Mexican patients and Mexican American patients who welcome spiritual care. And again, I find that a great asset because spiritual care is not only helpful to them, but to the whole team who can be grieving situations where we can't be of more help with our treatments. Something about our medical cultural milieu today assumes that we are in command of our end-of-life decisions. That's patient self-determination. That has lots of great elements and aspects to it. But again, that may be very unfamiliar to, say, a Latino who believes that God makes those choices. And I'm not in command of when I die or how I die. This is something that my spiritual life and beliefs should help me accept. So again, we're coming at things sometimes from distinctly different places, and we need to find the bridge where those can meet, where those can be discussed and engaged together.
Lo que me hubiera gustado de alguien que da un cuidado paliativo, primeramente es informarse qué es la situación de la familia, sentarse y escuchar su historia, qué es lo que a ellos les preocupa, cómo pueden ayudarles ellos. Tal vez ellos no les van a poder ayudar en cada cosa que ellos necesiten, pero si tienen recursos que puedan dar o buscar para esa familia, para buscar el bienestar de ellos. Y también preguntarles si hay algo que ellos sientan que los confortaría más, por ejemplo, religión o yoga o no sé, cosas como naturales, alternativas. Y más que nada como si pueden proveer a alguien que hable tu idioma, porque eso es la elemental para hacerte sentir bien. Y creo si pudieran dar a una persona que pues que no te dejes desesperanzas, pero que tenga buen humor o que te haga sentir pues que te va a ayudar a dar ese paso y que están ahí para escuchar las preocupaciones de la familia y tal vez que se sienten a conversar con la familia para que la familia entienda qué es el cuidado paliativo.
Bueno, yo lo que digo es que con las enfermeras nuevas que van a empezar a trabajar con pacientes, que sean muy amables con sus pacientes y que les tengan calma, que sean cariñosas y pues amables más que nada con un paciente, ¿verdad? Porque un paciente pues por cualquier cosita, aparte de que están con su, ¿cómo diré? Con la enfermedad, ¿verdad? Con la tristeza de la enfermedad y luego aparte que tu doctor o tu enfermera te trate mal, pues más te acaba. Entonces yo les pido que les tengan paciencia, que sean cariñosas con ellos, muy amables y todo.
I don't think nurses do this as often as doctors, but there's the tendency to label patients as non-compliant or to recognize they don't trust us as if that's their problem. Where what's really required is for us to realize when patients don't go along with things that we really feel strongly are in their best interests. It may very well be we haven't been effective communicators about that, especially across cultural differences. And when they don't trust us, there's probably some good reasons for that. There might be a long legacy of discrimination toward them and their racial or ethnic group, or toward them as individuals. They may have been treated badly elsewhere in the healthcare world. It's very common, and it results in mistrust that we have to bridge. So I think that it's going to be important for us in working with Latino families in palliative care, just as in the rest of healthcare, to be great listeners, to be responsive to these changes, to be able to take the time to recognize the changes as they emerge. So I can't predict what the changing American demographic and the predominance of Latinos in our society is going to do that demands change of our healthcare world, but I can promise that it will. I'd like to think that it will help infuse us with less fear and more interest in engaging spirituality in healthcare. I'd like to think that it will change how much time we think it's acceptable to take with patients, because some of the discussions we're talking about on this subject can't be done in 10-minute visits in a doctor's office. I'd like to think it will help restore to the nursing profession its very time-honored approach to promoting patient psychological comfort, something that has been challenged by the industry in the last generation. So I think what we need to do is be exceptionally good listeners, self-educators, and find ways to provide the time and the interdisciplinary approaches with teams that will, again, reach patients and families where they need to be reached. And that's really going to be beneficial with working with Latino families.